What's up, guys? Jay. Quick reflection on a case. 33-year-old female presenting with, in her description, that was sort of shoulder pain. She felt like it was shoulder pain. When I asked her to describe the location, it was sort of upper fibre trap on the left, and actually in kind of further questioning, if I asked her, "Do you have any pain on your shoulder blade?" and I visually show her that, that area, and she's like, "Oh, actually, yeah." Any pain below your elbow into your arm? Yeah. She actually had, as it turns out, symptoms going down all the way into her hand, fourth and fifth digits, kind of medial aspect of the forearm, which, if you're thinking in terms of kind of dermatomal distribution, we're getting into that kind of C8 to T1 dermatomal area. And when you're looking at, if somebody has a specific area distally, because initially she went hand, and I said, okay, well, in your hand is anywhere specific, because some people won't know, some people just say it's just generally all over, but if you've got a specific kind of dermatomal distribution, a dermatomal pattern, that in itself is a clue that you're looking at kind of a more of a potentially a radiculopathy than like along the line of symptoms related along the line of a peripheral nerve or a peripheral neuropathy, that kind of stuff. And so that was really useful information, but the point I'm trying to make here is that it wasn't freely presented. I had to prompt her, I had to dig deeper to get that, because in her mind, if I just went off her description, she said shoulder, and it's probably her neck. Well, it is her neck. And two, she wouldn't have told me those things if I hadn't asked her. So really useful to ask those specific questions along the lines of what you're thinking. I'm not leading her into the question. I'm like, do you have pain here? Yes or no? And I'm keeping it very close-ended, because I don't want this to kind of, people can go off on one like, oh, back in like 10 years ago I had this thing on my, like, do you have it here? Yes, no. Really, really simple. Rather than you don't have pain in your shoulder blade, do you? I'm not leading them into saying yes or whatever. Anyway. So that was on the location front. And what I found is, given the fact that she'd reported these kind of, and she said numbness rather than pins and needles. So, we've got some neurogenic symptoms there. It was intermittent, but in my head I've gone, right, we're definitely doing our neuro assessment. So that was the first thing I did, priority kind of wise. So we did her dermatomes were all normal, but muscle power is reduced in that thumb extension, finger adduction. So again, that correlates with her symptom distribution, dermatomal area, and you've got less segmental overlap distally as well, so you can be more kind of certain that it's kind of those specific areas, and if they're reporting it more proximally. So that's something. And then the sort of C8T1 myotomes also matched up with that, and they were maybe like a 3+ out of 5. So certainly not a kind of equivocal sort of response on that assessment. Then we found that, because she was reporting that no night pain, no, apart from her family history of some breast cancer on the maternal side. She didn't have any past history of cancer, and all the subjective screening for malignancy and any red flags were all negative. The one time that she did really get pain was just at work, sitting, and she felt like her belief that it was due to posture. We found on the cervical screen that sustained flexion, passively in supine or even in sitting, consistently reproduced the pain, particularly if it was sustained, and would refer. So she's got that kind of, almost like, you can think of that as the person like with the lower back, the discogenic flexion intolerant, who if you send them forward and you keep them in a forward bend will start to get, they have a directional preference basically. So it's almost like the typical, like, it's the head and neck version of the sciatica, if you want to put it that way. And that's really good because it gives you clues. So when she got that, and we had her propped up on a couple of pillows initially, which is saying that's really uncomfortable, I was like, okay. So whipped out all the pillows. I created with the towel over there a little makeshift cervical pillow to maintain the lordosis in your neck. Instantly gone. Instantly, oh, that feels way better. Like, okay, great, cool. So then I'm like, well, okay, so let's extrapolate these positions into sitting, which is your most pain-provoking activity. Can you see how if you're spending prolonged periods in in a greater or lesser degree of forward bending, looking down, that eventually that's going to build from ache, tension, pain to potentially even referring down your arm, give you that numbness. So the rule of thumb is bring the objects and the screens, phones, tablets up to you rather than you going down to them. And the example I use is that imagine with your lower back, is you're going into and out of that forward bend, but you're never kind of really staying there for very long. And it's fine, like this isn't an abnormal movement, it's not a dangerous movement. I'm not kind of creating a yellow flag, I'm not kind of creating any fear avoidance or hypervigilance or anything. I'm just saying you're sensitive to that movement, you're just intolerant to that movement because you've spent such a long time there that you've exceeded your kind of your tissue's tolerance for being in that position. So if you think about the lower back, it's like, imagine it's almost equivalent to you sitting down at your desk, minute 1, and just staying like this. You know, and eventually that tension builds up in your paraspinal muscles, and if you were to stay there and ignore it, kept going, it's going to get worse and worse. And then next time you go to lean forwards, because your pain threshold is reduced, you can't spend nearly as long there before it starts to get painful. So the goal then, what we're looking at treatment wise is she's got a directional preference, so we're going to do ergonomic. We're going to fix all the ergonomics so she's not in sustained flexion. We're going to do work with that directional preference. So I did some sort of Mackenzie side glides, ipsilateral kind of repeated loading to the affected side. I found that really effective with this kind of presentation. Repeated motions into extension probably as her rest break movement, breaking up any prolonged periods up to 20 minutes, 1 minute rest break, do your repeated motions, 10 reps or so up to every hour, to mitigate the effects of the prolonged flexion. We're looking to centralise her pain. If you want to talk about this in like Mackenzie terms, it's kind of a bit of a postural. She's pretty young, and I think she was bob on. This is one of the times where it's worthwhile acknowledging what patients are sort of thinking, what they think is going on. I think they appreciate that. They're not, a lot of times they're way off the mark, but this time I agree with her. I do think it was a big contributing factor, and so that is something to work on, and empowers her that she has control over education and knowledge. So she's in control, not dependent on me to just do manual therapy all the time. Manual therapy is just an adjunct to help facilitate her recovery. It's not the mainstay treatment. And what was the other thing I was going to say? Right, so it's postural dysfunction, but it's also a bit of a derangement because she's got that kind of radiculopathy presentation. So anyway, that's it. I had good results from session 1, and I said to her, from past experience, I've had people just do the modifications to the posture, and they're better by the time they come back after session 1. So I'll let you know how it goes.